Welcome, everyone, and thank you for joining us for this third session of the Kenya Primary Healthcare Learning webinar series. In the first session, we introduced discussions around primary healthcare financing. And for this session, we are going to do a deep dive. We all agree that when primary healthcare works, communities feel it. But when it doesn't, the reasons are often invisible. But sure, financing is almost always part of the story. Today's session, The Money Behind the Mission Part 2, focuses on how primary healthcare flows across Kenya's healthcare system, from national reforms to county budgets, from facilities to community services, and ultimately to the household and individuals seeking care. We will explore how current financing reforms are reshaping primary healthcare, what counties are experiencing on the ground, and what lessons we must act on now to ensure financing truly supports people-centered, equitable PHC. This is a learning space, a dialogue, and an opportunity to bridge policy intent with implementation realities. We invite you to engage actively, share your county perspectives, your perspectives from other settings, and help us turn learning into action. My name is Melissa Wanda. I am a policy and advocacy manager with PATH. Allow me to introduce our speakers, and as I do so, please feel free to introduce yourself in the chat. We will have a session for Q&A, but feel free to put in your questions even as we proceed with the conversations. So feel welcome, and allow me to introduce our speakers today. Slides, please. In this session, the session will be kicked off by Dr. Joel Gondi, the Director, Primary Healthcare, Minister of Health, Kenya. Dr. Gondi holds a Master's of Public Health from Vrije University in Amsterdam, alongside other medical and executive trainings. He is a seasoned advocate. He has led key national initiatives and development of policies to address non-communicable diseases and improve access to quality health services. Welcome, Dr. Gondi. We will also have Dr. Salim Hussein, who heads the Division of Primary Healthcare Networks. For those of us in the primary healthcare space, we are familiar with Dr. Salim, driving action towards institutionalization of the PCNs, as well as working closely with the cross-cutting divisions within the ministry to make sure that we are addressing the PCNs as a health system strengthening approach to be able to deliver care to the most vulnerable in our communities. We will also have Dr. Stephen Kaforo, who is a health economist with the Healthcare Financing Directorate within the Ministry of Health. Kaforo is an economist with over a decade of experience driving health financing reforms. He is a key architect behind the transition from the NHIF, the National Hospital Insurance Fund, to Social Health Authority. He has served on multiple ministerial task forces, strategic purchasing, output-based budgeting, and developing the algorithm that now determine premium contribution for the informal sector. We welcome Kaforo. We are also glad to have Dr. Teresa Tracy John, who is a Senior Deputy Director within the Health Financing team at the Ministry of Health. Dr. Tracy John holds a master's degree in medicine. She holds a bachelor's degree in medicine and a master's in neurosurgery and an MBA in international healthcare management pursued across UK, Zurich, and Nairobi. She has played a pivotal role in advancing sustainable healthcare delivery over the course of 20 years in experience in health policy, system management, institutional leadership, and our expertise is both in clinical practice as well as health financing. We welcome Dr. Tracy Jones. We also have with us Dr. Julie Zulman, who is with the Health Insights, and I'll be able to introduce her when she'll be speaking. Allow me to introduce Dr. Gondi to get us started, and then we hit it off from there. So Dr. Gondi, over to you to just lay the ground for our conversations today.
Thank you, Melissa, and thank you, the panelists, the other panelists. Welcome to this session. I am actually in the field, so accept my apologies. You might get one or two issues not as clear. I am glad to be in this session today, being a follow-up of what we had, I think, late last year. And when you're talking about now the financing primary healthcare, the mission behind the money, I've been reflecting and I'm asking myself a few things that we need to probably look into. So, colleagues, ladies and gentlemen, I would like to welcome you to this important conversation, the money behind the mission, financing primary healthcare. This subject is actually at the heart of our journey towards UHC. Let me frame my remarks on questions like I did last time to guide our common reflection. The first one is our primary care, is our PHC model the right one? And why does this matter? I'm asking this because are we fully aligned on the fact that Kenya has embraced a comprehensive community-centered primary healthcare model anchored in preventive and promotive community health units and community health promoters, integrated services at levels 1 to 3, and a people-centered approach with not disease-centered care. And if this is the case for our model, are we financing it accordingly? Are we still disproportionately funding curative, hospital-based care programs and programs? If this is the approach, what proportion of the resources is going towards this as compared to what is going into the primary and to the other programmatic areas and the curative care? Because the money should actually follow the money, what the mouth says. How well is this model performing currently? And for us, the people who are on this call, how can we say how mature it is? Can we confidently say that community health systems are fully functional and sustainably financed here in Kenya today? Are we sure? Can we say that the over 107,000 community health promoters are supported well and are doing the best that they can? Are the primary care facilities adequately resourced by the staff? Are they staffed? Are the equipments right for these people to offer the services that they need to offer? And currently, we are glad that the primary care funds is already flowing. But is that financing adequate? Is it being used well for community work and for primary work that it is meant to do? How supportive are the other financing arrangements at the county level to support this process? Or are we still in a transition phase where we're busy establishing systems, but we've not yet optimized? The gaps are visible, but yet are not equitable across the counties. Why are the financing flows still fragmented and predictable? So really, the key question that then comes, are we scaling a mature system or building one while simultaneously expecting results? These are the questions that we should be asking. And of course, we should be very clear. What challenges constrain our effective PHC financing? We must be clear by now the major drivers that should be addressed and not complaining about everything. What are the major challenges that we need to be fixed so that we can make it to the next level? And of course, if PHC is still underfunded and we have fragmented systems where the national financing and versus the county, the donors are still playing in the field, the issues around delayed reimbursements and inefficiencies in the fund flow, then are the human resources for PHC at the community level, at the facility level, optimal? And if not, what needs to be done so that we can actually say that we have put optimal investment for our PHC to work. And of course, probably, do our financing mechanisms reflect our policy commitments, or do they contradict them? Because if our financing is not giving, supporting the direction of the policy, then we need to honestly reflect and see how to move forward. And of course, all these problems, we know them. How do we mitigate these challenges and move from intention to impact? If we unlock the full potential of PHC, we must ask ourselves, how do we reorient the financing towards prevention and early interventions? How do we pool resources more effectively and reduce fragmentation? And of course, how do we work, or what systems do we need to put in place to ensure that there's a predictable, timely, and adequate financing for community health services, rather than putting them at the peripheral? We are giving CHPs resources. We are putting money into the activities. What are the results? What are we getting? And what can we report to the Kenyans as the early gains that are beyond the input and processes into tangible health outcomes? We must look into issues how national policies align to the county implementation and partner support so that we have a coherent financing framework. Ladies and gentlemen, as we do this, we must invite us to reflect on one central question. If primary care is the foundation of universal health care, then we need to treat it as a foundation. Or are we treating it as an afterthought after everything else? The answers we generate today must move us beyond dialogue to decisive coordinated action. I would like to encourage you to have open, rich dialogue that informs us from moving from intention to impact. Thank you very much, and I welcome you to this dialogue session. Asanteni.
Thank you so much, Dr. Gondi, for setting the scene there for us, asking very critical questions. When primary healthcare financing is not making sense, then what are we doing? How are we reorienting our financing to make sure that our primary healthcare makes sense? That at the last session, we talked about getting more health for money. How do we get primary healthcare for the resources that we currently have? So that brings in the conversation around efficiency. And there was a lot of interest around financing flows. So for this session, the objectives are to strengthen county capacity to effectively manage PHC financing flows, ensuring clarity on resource allocation and utilization across all levels of service delivery. The second objective is to showcase county-level experiences on primary healthcare financing flows. And so you'll be hearing from county voices. From Mombasa, we have the Council of Governors, and we have a couple of other counties represented on this call. And please feel free to add into the conversation, add your points to the chat, but we'll also have a Q&A session where we'll be able to grant you that opportunity to voice your perspectives and some of the experiences that you're seeing. The third objective is to deepen our understanding of the Social Health Insurance Act of 2023. And that is where we are going to start from, especially since it entrenched other financing mechanisms that are critical to delivery of primary health care. The fourth objective is to clarify the flow of facility improvement financing resources to primary health care. And this includes the role of Council of Governors, the partners, and the counties in implementation, as well as accountability. So thank you very much. And allow me to let in Dr. Stephen Kaforo. Dr. Stephen Kaforo is just going to give a highlight of what the government is doing in terms of reorienting the financing. How is the flow as it is at the national level? And at the county level, of course, we'll be looking at how that current system of how funds flow affect service delivery, either positively or negatively. Dr. Kaforo, Stephen, welcome.
Thank you very much, Evangelista Wanda, for that great introduction. I think I'm going to give both two viewpoints of the financial flows. One, what the government is doing, and more importantly, I'm going to give a bigger, broader objective on PHC in the international context. and how that affects our interpretation and also our trend analysis of how we have been financing it in Kenya. So, if you don't mind, you could kindly give us the presentation. Yes, thank you. So, I will have just a brief introduction of the presentation. Allow me not to have the video on because of most people I know will be needing a lot of data on this. But the presentation will have just the outline, one defining and giving a small background on what PHC is. Then we look at the funding sources and who provides the services for primary healthcare in Kenya specifically. We also have a brief overview of a trend analysis. I used just basically a proxy indicator here just to give a long-time trend analysis. And then we look at the main implementation issues that we have seen in the country and the expected reforms. Yes, so with that, I think panelists and members, I would like to go directly to the definition. And I will draw this definition from a framework which is mainly used for estimating and looking at financial flows within the health sector. And this is called the System of Health Accounts. The System of Health Accounts is developed by a global network of partners and coordinated by the World Health Organization. And basically, it gives two broad definitions of primary healthcare. The main one being the primary healthcare is all health measures that are done by a country or by the people in a country to ensure that they avoid disease or they avoid the risk factors that expose them to diseases. And this is done in three main ways. Number one, any set of activities that are done to reduce the onset of a disease or diminish new cases of a disease that is already present. For example, when you have HIV or when beforehand we had the pandemic. So any activities that ensure that we do not see more cases of that disease. And lastly, any activities that are used mainly geared to anticipate early exposure to a disease. That is in terms of emergency preparedness, looking at how they detect and avoid diseases. So within that broad framework, the System of Health Account lists some of the potential interventions that are included in primary healthcare, and that include things like circumcision when it is specifically done to prevent HIV/AIDS, nutrition measures that are done in the population, maternal health, especially when you're protecting mothers from further complication and ensuring that there is safe delivery of new babies. We have primary health services. This is done mainly at households or at lower level health facilities. And you have other things like immunizations and vaccinations that are done to prevent onset of a disease. We also have a second, more technical definition, which mainly lists any interventions that are geared towards detecting diseases and then ensuring that in case a disease is detected, there is early inclusion of that case into early therapy. For example, when you do screening for cancers, hypertension, diabetes. And it also ensures that we have secondary prevention of mix that one. So it also ensures the secondary prevention therapy that increases opportunities to ensure that there is less cost and less interventions for diseases, thereby reducing the stock of illness in a community. So that's the more technical definition of PHC. So you'll notice that, and as Dr. Godi preempted, primary healthcare looks more broad rather than what is done at community, but also any activity that is done to prevent the onset of diseases or the spread of already existing diseases to the other general population. Now, if you look at our Kenyan key definition and background, where we have brought the issue or the policy on primary health care, there has been an existing policy. I don't know if it has already expired, but I think it was mainly active between 2014 and 2024 on primary health care. It drew its inspiration from the Matter Declaration, which was mainly um, urging countries to move towards improving health rather than waiting for diseases to come and then you try to cure the diseases. So in Kenya, they mainly drew from that, the primary health care policy, and it usually customized it into the Kenyan context and gave the specific areas that they wanted to really focus on in Kenya. First one being the establishment of primary healthcare networks, which will be at the community level and mainly focusing on community key interventions that affect each community. You know, each community will have different profiles or disease risks. So this primary care network was supposed to ensure policy making and disease intervention is cascaded to the community level. Then, of course, ensuring that in case of such risk are identified, you can be able to do screening and prevention at that lower level, basically at the community, dispensary, and the health center level. And it wanted to ensure that there is a proactive, because we have the community itself speaking into their own issues. So we have proactive, personalized, coordinated, and integrated health services at that level, ensuring that we ensure the communities themselves are at the forefront of identifying the disease risks and mitigating this disease risk at the lowest level. The overall goal of that strategy was to ensure that we reduce the care, we reduce disease episodes, and we ensure that people do not always have to wait to get sick in order to access health facilities. Now, before we go mainly to where these services currently are or current trend, I would like to give you a brief of of or a brief glance on who is actually currently financing primary healthcare in Kenya. And with that, I will give several examples. So most of this is captured in the health financing strategy. If you read it, it shows historically who has been funding and in future how we want that to mainly align into the future priorities of the country. So at the national level, the national government still continues to fund strategic key interventions that require high level, national level attention. And mainly this is through conditional grants and commodities for strategic health interventions. For example, vaccines, maybe procurement of malaria nets. Another key example would be in cases of pandemics, the national government is supposed to take lead and have emergency funds to take care of such pandemics when they come, as we saw when the COVID pandemic hit. Of course, we know as per the Constitution of Kenya, the actual service delivery is vested within the county governments. So they usually also finance their healthcare costs, including primary healthcare costs, either through what they receive from the national government as equitable share or from their own source revenues. One thing we usually tend to forget a lot is that primary healthcare is actually heavily financed by households. And the reason being that households are usually the biggest and the largest and the most effective provider of health service within themselves. So things like water, sanitation, hand washing, ensuring things like the warming, those mainly are done at the household level. So the household will usually finance majority of these costs at that level. We also have households financing some key interventions that necessarily do not escalate to government or facility levels. For example, preventive measures, for example, things like early pregnancy prevention, things like circumcision to prevent HIV/AIDS. We have things like family planning and birth spacing. Such things are usually mostly done at the household levels, and the household finance that and produce healthcare within that level. We also have issues where households prefer to treat themselves, especially for mild conditions, things like stomachache, headaches. Sometimes households will prefer to treat themselves at that level. And I think in the last survey, we saw around 44% of people who report that they experience a sickness episode prefer to actually treat themselves at that lowest level. We have now introduced the Social Health Authority as another key funder, especially for managing funds that are nested within the national government and trying to see how these funds flow into the health facilities. So it does this through the PHC fund. Dr. Godi has talked about this. But also remember there are some primary healthcare services that are funded through the contributory social health insurance fund basket. This is the second tier basket shift. So there are some preventive care which is funded through that fund, especially maternal and child health and early detection of diseases. Some of it is funded through the SHIF funds. Of course, development partners come in, and mostly they either come in through the national government or they offer funding directly to the facilities or to the communities to fund primary healthcare services. So those would say are the five main key areas where primary healthcare service get its funding from. And once these funding are catalyst or they are available, they usually are provided through various providers. Now, in Kenya, the various providers that we have for primary healthcare services, in the next slide, Melissa, you will notice, and I think this where Dr. Gondi was coming in to ask, where are we giving these services? Now, what I'm presenting there is not the amount of money that is flowing to the facilities, but rather the primary healthcare services visits where the visits occur. So in case we have need for primary healthcare services outside the home, outside the household, where do the household seek these primary healthcare services? Surprisingly, as Dr. Godi had observed, government hospitals and private FBU hospitals usually take almost half. And these are high level facilities. They all take up almost half of the primary healthcare workload that needs to be attended at facility level. Now, this data is a bit old, and this is the one shift which we are trying to change with the current reforms, but we will look at that much later in the other slides. But historically, we have seen a lot of primary healthcare services being sought in these high-level facilities. But at least we are seeing a gradual shift. So currently, we have government health centers and dispensaries now taking about a third of these services. Then we have private clinics and also chemists and pharmacists taking up another almost a fifth of that cost. And we are feeling that in future they should start shifting towards more of both private and FBO clinics and government health centers and dispensaries, trying to lower it to the lowest level. In the next phase, we are also going to see chemists and pharmacies being brought into, but especially when we have already the service having been dispensed at either the clinic or the dispensary health center, and drugs and services can be sought at the chemist level or at the pharmacy level with a reimbursable cost to it. So currently, this is how the the providers are distributed when you look at the workload, and where the workload mainly goes when they are seeking services. No, those are mainly showing the overshoot on what services are, where the money is coming from, and who is giving out these services. There is one question which Dr. Godi has asked: how much is being um, allocated towards primary healthcare service? Now, in the next slide, I will give one caveat. We have not, as a government, especially as a national government, done in a national account specific with a sub account on primary healthcare services. They're hoping maybe within this space we might get some funding to do specific sub account on primary healthcare services moving forward. But historically, we have a good, I would say, predictor or dummy, which I can use to show roughly how much or how stable the trend has been for funding. So we know preventive and promotive services are part of primary healthcare services. Promotive and preventive service, in this case, I mean services that are being offered either at the community level or at the lower level facilities, but mainly geared towards preventing disease and promoting health. So this will include things like nutrition, immunization, vaccination for the general public, things like circumcision for HIV/AIDS, ANC, it's called ANC and PNC for that's antenatal care, postnatal care for mothers, full immunization, etc. So those are what we have been able to track consistently over time, and we was able to get a very good trend analysis going all the way back to the last 2 decades. And we do notice that Kenya has averaged around 15%, except for 1 year, I think 2009, 2010, when that figure was actually quite high. But if you remember the kind of chaos that had happened around that time in 2008, we had the election violence. And the government that came actually tried to focus on what we were calling ESP. So trying to stimulate the economic stimulus project for government, and PHC was actually slotted to be one of the key areas. You remember that's also the time when we had a specific ministry with a specific minister responsible for issues of primary health care. And we could see there was a huge increase. But after that, the amount allocated towards the preventive and promotive healthcare has stabilized between 16 and 14%, between 14 and 16%. So at an average of around 15% of the total health expenditure. Now, I also want to give the second caveat here. This is as per the total health expenditure, not government expenditure. So this includes all the monies that are allocated from development partners, from NGOs, from private philanthropies, from households, from insurance companies, and also from the government itself. So if you include all that money, how much actually goes to, of you mobilize all those funding, the ones I had presented in the previous slide. If you have all that, how much now flows to preventive and promotive health, just as an indicator of primary healthcare service. Now, for primary healthcare service, the scope, as we saw in the first slide, is a bit larger. From the previous estimates which I was able to see, I think I only saw for about 2 or 3 financial years before 2020. The entire scope, as per the definition of the primary health care policy, and what is included as PHC in the primary health care policy in Kenya, the funding for PHC ranges between 50% and 65%, depending on the year. So I think I saw 3 years, but between those 3 years, it ranges between 50 and 65% of total expenditures going into the healthcare system, both government and non-government. So going into the key implementation issues, and this, I have seen that Dr. Goody also touched a bit on this. We have, I think, four big issues which we have seen affecting implementation of PHC. One being the fragmentation of financial flows, where we have seen that no one entity has control of how much money or how money is flowing from the different actors, from donors, from national governments, from counties, from NGOs to the implementers. There is very limited coordination that is seen within there. The second thing is that the visibility of PHC funding is still not very prominent. As you have noted there, even at the national level, we have not been able to actually tease out and have a sub account. And we hope within the current almost concluded national health accounts, we will get financing to tease that out. But we notice that that has not been teased out, and most of the time, primary healthcare fund budget is buried into many underlying budgets. In some counties, you find PHC services under one budget called hospital services. That's where you find even community health workers. In some counties, like northern counties, I saw a lot of budget for PHC being done at the administration line items. So that kind of hides how much goes into the primary healthcare fund. Of course, we have the issue of parallel financing. So we have donors flowing money into the counties without visibility of either national or county governments, no control, and sometimes it ends up duplicating. For example, in some counties, we have seen issues of healthcare workers being paid by two agents, a component being paid by the national government, but there's other components, top-ups that are paid outside the framework of wage management in the public sector. So those brings a lot of distortions into the market, into the service delivery. I know at the ground level there are, of course, justifications why such needs to happen, but in the overall issue of managing budgets and managing transitions, it becomes very difficult. Sometimes we have suboptimal facility investments, and this we have seen especially with the explosion of lower level facilities. The health centers and dispensaries have grown by more than 90%. Maybe driven by investments by both the county government and the private healthcare providers. So we have seen a lot of private healthcare providers establishing lower level health centers, dispensaries. But in some instances, you find that these facilities are suboptimally equipped. If you move to private health providers, you find that they're adequately equipped in terms of commodities, but they lack healthcare workforce, or they rely a lot on locum from government workforce to run their facilities. Then when you switch to the government facilities, you find that they have enough or almost enough workforce, but they lack things like lab diagnostics and issues like commodities are not adequately supplied to this facility. Sometimes you even find facilities that do not have electricity to run their labs. So that becomes a common issue. Now, not very related to that on the key issues, but things that we have noted that reforms that would be needed to somehow start accelerating those key issues that we have highlighted. So we noted that if we have like 2 or 3 main reforms, they could start gearing or guiding both the private and the public sector towards aligning the delivery of services into more optimal way. For example, we have identified the issue of pooling, and you're saying that going forward, to reduce this fragmentation, we want to see funding that is coming from donors to have a way of being channeled, or even if not channeled, but being accepted and be prioritized at the county and the national government level, so that we ensure we see where the money goes, what the money is going to do, and the outputs. And we also ensure that there are no duplication when the money goes. A good example would be what you're doing with the USAID. This is government to government. And we have also several other partners which are also doing government to government agreements. to ensure that this funding is more visible, is more coordinated, and it flows well to the county. Another example would be what we are doing with the World Bank funding. That money is flowing with clear government-to-government agreements, both at national and county level. Second one is in terms of purchasing. We have seen a lot of purchasing of input. So a lot of time we talk about how we are going to pay HR. We need to increase the HR from, I don't know, from 10,000 to 20,000 without any clear reasoning why. I mean, is it driven by an actual need? Is the actual gap there that we need to give this gap? Of course, we know from literature, the theoretical literature that is there, but there are a lot of things that affect that literature when it comes to the actual economic implementation. And within this, we are saying we wish to see a progressive move towards funding outputs, so that if when we are funding outputs and the outputs are clearly reimbursed for, then the implementers or the providers themselves and the managers of health facilities, for example, county government, sub-county government, private healthcare providers can be able to plan their investments well, know where to invest, know where they need more facilities, know where they need to reorient their workforce to. And this you're doing, for example, through the PHC financing. You have noticed that the way PHC is being financed from social insurance is different from what was there before. So we are trying to see, to finance a lot of outputs, not just capitation. And you're planning to move that further and scale it up even to other forms of government payment schemes. The last thing which we noted and which we are actively trying to reform and move the country towards is the issue of accountability, whereby we usually do not have a feedback loop. And for those who have been with us for the longest, ever since those times, the ministry, both ministries of health, we used to have two ministries of health. They used to control around 40 billion Kenya shillings. And that was just like, I think around 10 to 15, around 15 years ago. That financing has increased from around 40, 50 billion currently. Now we have both the national and the county allocating to health, giving a total of almost 300 billion. So almost a tenfold increase into the health basket. Now, do the citizens see what this money is doing? Are they able to see or have a feedback? Do they feel that this money is flowing correctly to what they want funded? Those are things we want to have a look. And we are developing something we are calling the health financing framework model, which we want to be maybe in the next within the year or by next year, it will be on board. But this is one of the things that we want to have a feedback loop from the community through the managers at the sub-county level, managers at the county level, community health, or community-based organizations, CSOs, the county level and national government, even national treasury. We can be able to have that kind of a loop and see what is happening. I've also seen a number of pilots also in the same area about feedback and paying for output being implemented in pilot basis. I think there was a good presentation from Kisumu. I think we will see it in our other discussions. But these are some of the key reforms. I would say the three key reforms that we are trying to drive at the moment to ensure that we actually solve our main issues in the primary healthcare service delivery space. So with that, ladies and gentlemen, I would like to end my presentation and give it back to Melissa for further guidance.
Excellent. Thank you so much, Kaforo. Thank you for defining primary healthcare. I remember when we were first looking at budgets and we were wondering, if immunization sits under primary healthcare, do we also have circumcision? Do we want to include malaria? So thank you so much for working on that and just defining some of the parameters for primary healthcare. I love that you have outlined the role of communities in disease prevention as well as health promotion, and that is really critical. So thanks for highlighting that and also sharing some of the upcoming updates, including the health financing framework model. And we are really looking forward to providing inputs and to just strengthening any area that might require community and partner voices. Listening to the gaps, I do see roles for everyone. When you talk about pooling and how sometimes, we don't have a consolidated approach, how are we as implementing partners enhancing integration? Because when we say we want to get more primary healthcare for the money that is already there, that means one of the ways that we can use is increasing efficiency. And that would be one of the ways, again, is integration. So integration, enhancing efficiency. So how can we better do that together? I love the proposal that in terms of purchasing, it should be focused on outputs and not just inputs. Of course, for accountability, it goes without saying that we need the voices of the community and the end service users. I am going to continue with that same discussion, and allow me to introduce Dr. Tracy John. Dr. Tracy John, so you're the first one I'm going to introduce on this second segment where we are having a panel discussion. So we have speakers, we have Dr. Julie Zolman, we have Dr. Tracy John, and you'll also be hearing county perspectives, and we'll be hearing from Dr. Salma Swale Mohammed from Mombasa. So let me start with Dr. Tracy, just to align with what we are hearing from the presentation that Kaforo has just shared. So thank you very much, Dr. And thanks for joining us. So I wanted to ask you, what mechanisms within the new reforms are designed to protect the primary healthcare financing and to ensure that resources reach the front line? Kaforo has outlined the structures as they are and what should be happening in terms of flow. What are some of the early implementation lessons you can share? What can you share with the counties in terms of the counties positioning themselves to get the best out of these reforms? How is the alignment of the social health insurance fund, primary healthcare fund, and the county systems? So Dr. Tracy John, take it away.
Good afternoon. Thank you very much, Melissa. I hope I'm audible. First,
Yes.
I would like to say that, okay, all right. On that question of how the current health financing reforms are aligned to protect the primary healthcare financing, quickly, I would like to give in summary format. In the structure of the health financing reforms, we see a deliberate effort to ensure that the Kenyan populations have access to primary healthcare services without experiencing financial hardship. And how this is designed is we see that the way the benefit packages are designed, starting from the level 2, 3, and a bit of level 4 facilities. These primary healthcare services are provided in the benefit packages and are accessible to all Kenyans without the need to pay up premiums. And this was a deliberate effort to make sure that ability to pay is not the deciding factor, so that then we can have more value for money in terms of making sure there is access to these health services, financed entirely by the government through the exchequer, so that there's no limitation. Secondly, in this same financing mechanism, we have onboarded the facilities that are providing these services, as has been shown in terms of the mixed method where we have private faith-based facilities as well as government facilities are all contracted to provide these services, and they are reimbursed from the primary healthcare fund. And this ensures that access is not limited by the type of provider. And this has really worked well in terms of also boosting the public facilities to be able to have access to resources and to boost the services that they're able to deliver. Thirdly, other than the facility-based primary healthcare services that are financed by the government, we also have the level 1, the community-based primary healthcare services that are also entirely funded by the government. And this is very important to make sure that all households can be able to access these services without the need to pay for them. So through the community health promoters who are supported by the government through various means. And also, additionally, the county government also having other mechanisms through the environmental health initiatives and the other players. Then we see that at the community level, also there's a deliberate effort to make sure that the preventive and promotive services are very well anchored in terms of financing and can be provided to the populations without the need to pay for them. The last one I would like to mention before we delve further into the details is the fact that even where there were limitations of the primary healthcare facilities in terms of the capacity to provide these services, then there was onboarding of the level 4 facilities in those especially geographical areas where the access to the level 2 and 3 capacity may not have been beefed up. So that also made sure that there is further protection, ensuring the combination of the services are well provided. And also, when we look at the benefit packages, the services that are provided at this level 2, 3, and parts of level 4 combines the full spectrum, looking at not just the curative, but also combining with the preventive, promotive, and rehabilitative services, as we can see from the interventions or the services that are captured in the benefit packages, to make sure that we are controlling disease and also preventing disease early enough. And also, just to mention that also the other interventions that are at the primary health care that also probably financed elsewhere, maybe external funding, also looking at how to start the integration into the local or internal mechanisms of financing, so that we also strengthen that element of financing, whether it's in the areas of vaccines for immunizations, whether we are looking at conditions that require heavy investments to ensure that the disease control is achieved. Thank you very much, Melissa.
Thank you, Doc. So when we talk in terms of sustainability, what do you foresee as some of the guardrails for some of the efforts that you've outlined that have been put in place?
Thank you very much. Definitely, as the sustainability of primary healthcare financing is very critical, because then we have to sustain the gains, we have to sustain the efforts, not just for the day, but also looking into the future. And one of the strategies to ensure that the sustainability is to see that balance is well handled in terms of where we are putting the money, because then we know that if we neglect the preventive and the promotive arm of the services, then that means that we encounter more diseases coming in new cases, and that means spending more on the curative arm, and therefore investing intentionally in the preventive and promotive arm of the services then becomes critical in terms of sustainability, so that we can move forward knowing that we are not just treating, but we are also controlling the emergency of new diseases, and therefore spending less. Also, we know that when we spend money for healthcare in the lower level facilities at the primary healthcare level, the cost of that care is much less compared to financing the same in the higher level facilities. So also strengthening the referral systems becomes critical to ensure that we are not having a flow or an influx of patients or clients moving to higher levels for care where it could have been treated at the primary health care facility. So that gatekeeping, making sure that only those who need to move to the higher levels move up in terms of seeking services, and also to be able to decongest the higher level facilities, so that then they can be able to concentrate on the more complex and conditions or services that require more resources. So those are some of the strategies, and just ensuring that we look at a multi-sectoral approach, because essentially prevention and control of diseases is bigger than the health sector. In fact, most of the interventions tend to lie within other sectors, and therefore seeing the boost of that multi-sectoral collaboration, also dedicating finances in those other sectors, finances that are visible and that we can track and say that this financing has gone to a health intervention, whether we are looking at the sectors like education, looking at transport, for road safety, whether we are looking at Ministry of Agriculture for nutrition, all these other enablers of health, we have to look at them holistically and track and allocate resources adequately, so that then we can have better efficiencies and reduce duplication.
Absolutely. Thank you so much. I love that you have brought out the social determinants of health that then have an impact on delivery of primary health care. So beyond financing, we have to fix the referral system, and we have to think about equity. So thank you so much, Dr. Tracy. I want to pivot to the county. Dr. Salma Swale Mohammed. Dr. Salma is the County Director, Public Health and Disease Prevention, Mombasa County. She holds a Bachelor of Dental Surgery from the University of Nairobi and a Master of Science in Health Systems Management from Kenya Methodist University. She has advanced training on leadership and strategic management, and she is also an affiliate of the Kenya Dental Association and the Kenya Medical Practitioners and Dentists Union. Allow me to pivot to you, Dr. Salma, to share county perspectives. From your county, what does primary healthcare financing flow look like in practice? We've heard from Kaforo from the national level. We've also heard from Dr. Tracy John. How does this look at county level? From budgeting to service delivery, where do the bottlenecks mostly often occur? Dr. Salma?
Thank you very much for this opportunity. Mombasa County has fully enacted and operationalized the facility improvement financing across primary healthcare PHC facilities. 100% of the level 2 and 3s generate and retain 100% of their revenue, enhancing financial autonomy and responsiveness to local needs. In practice, PHC financing in Mombasa is increasingly evolving into a blended model where we have a combination of the exchequer, the FIF, and the Social Health Authority reimbursement, which are gradually becoming significant source of financing revenue. The shift is transitioning PHC financing from input-based to output-based financing linked to service delivery. Budgeting and approval process starts from the facility, where they develop a quarterly budget based on the priority needs, which is then budget is reviewed and approved through a multi-level governance and leadership structure, where it goes to the health facility management committees, which initially review and approve, further taken to the sub-county health management team to ratify and align with the supervisory priorities, comes to the county director of health for review and ratification, and to be in line with the annual work plan. It is then taken to the chief officer, where final approval and issuance of the AIE. From there, now there is authority to spend, where the facilities are able to pay their casuals, bulk suppliers, utility, support outreach activities, CHP, defaulter tracing, and many others. The process ensures participatory decision-making, alignment with the health system priorities, and strong financial oversight and accountability. The main bottlenecks that we have is that there is limited financial management capacity among some facility charges, unpredictable funding flows, particularly delays in share reimbursement, affecting planning, limited visibility and reconciliation of share claims versus payment at facility level. We have actually using Taifa Care System. So we have Taifa Care System related challenges, where we have portal downtime, downtime taking too long. Sometimes we have issues of time attachment of requirements, and these affect the claim approval. We have mismatch between service delivery and claims reimbursed, leading to revenue gaps. The unavailability of specialized investigation and medication to support PHC facilities actually is affecting PCL because we have expert movement to lower facilities, but when they request for the specialized medication and lab is actually not available. There's inadequate funding for major infrastructure development and renovation. With the opportunities that we have under the social health authorities is that we have increased revenue generation for facilities previously offering free services. We have simplified registration processes. Only the ID is required. Opportunity for universal health expansion. Strong political goodwill, leadership support, positioning Mombasa as a national leader in SHA registration. We are at 79%. The transition to SHA presents an opportunity to strengthen strategic purchasing, where funds follow the patient. Facilities are incentivized based on performance. This has potential to improve efficiency, accountability, and quality of care if reimbursement systems are stabilized. The challenges within SHA implementation, we have some clients that lack national identification cards, which limit eligibility. We have a lot of foreigners that present when they're in critical condition. We have community mistrust and resistance to registration despite service being free. And the funding model does not support the hub. So PCN it's become difficult to strengthen our PCNs. In Mombasa, we have a unique challenge where some of our hubs are actually private facilities, hospitals, and some are faith-based. How do we strengthen the financial autonomy and management? And strengthening our, yes, please.
Okay, sorry.
Under strengthening financial autonomy and management, we would like to capacity build, train our facility in charges in financial management and the ICD 11 coding to improve claims accuracy and revenue capture. Introduction of internal audits in selected facilities with a plan to routine audit countywide. Enhancing financial governance and accountability systems. The county is also strengthening coordination between health and finance departments to improve predictability of funds flow and enhance alignment between planning, budgeting, and actual expenditure at facility level. Thank you.
Excellent. Dr. Salma, at some point I was about to call on Dr. Gondi and the team and of course colleagues from SHA on this webinar to respond to some of the concerns you have raised. But I love that the government is already putting in some work. The Department of Health is already putting in some work. Thank you so much for highlighting some of the enablers to sustainable primary healthcare financing, and the most important one being leadership and governance. So having that leadership, political goodwill goes a long way. And I think we had the same from Nairobi County when we were doing part one of this webinar. So for our teams from the Ministry of Health, please feel free to respond to any of the key concerns on the chat. To colleagues from counties and even partner organizations, please feel free to put in questions in the chat. We have one more speaker and then we'll open it up for questions. So when we talk about funds flow, and Dr. Salma has talked about funds following the patient, I thought about the financial diaries. And our next speaker, who is sharing partner perspectives, is Dr. Julie Zollman. Dr. Julie Zollman is a lead investigator on the Kenya Healthcare Financial Diaries and director of Eco Insights. She works with Eco Insights, which is a boutique research firm based in Nairobi. She studies the ways that ordinary people interact with and adapt to changing world, with a particular focus on digitalization, livelihoods, financial services, and healthcare. She was also the technical lead on the Kenya Financial Diaries in 2012-2013, culminating in the book Living on Little, which was published in 2020. So she'll be able to also share some of these insights from the previous financial diary. Dr. Julie Zollman.
Thank you.
What do households live? Sorry. Yes. Welcome. What do household lived experiences reveal about PHC financing gaps and out-of-pocket costs? I do recognize that Dr. Salma already alluded to some of this, some of the experiences that they are having in Mombasa County. And we just want to see from the diaries, what does this look like in terms of informal payments, financial vulnerability? What are we seeing versus what some of the reforms that our colleagues from the ministry shared, the efforts that are being put in place to enhance access to universal health coverage? So over to you.
Thank you. So for those of you who haven't heard of the Kenya Health Financial Diaries, we are studying 330 families across 8 counties in Kenya. We've been following them starting in July, and we'll be following them till November. Our team, based out of Georgetown University here in Nairobi, they are following every 2 weeks the same households, and we track all of their finances, their health issues, and their interactions with the health system. So the things we have to say about how people pay for care could fill many webinars. So I'm just going to focus on a couple of things that other colleagues have brought up today. So one thing that's very clear from Dr. Kaboro as well is that patients finance a lot of their own care. And they're sort of the hidden heroes behind some of our big health achievements. When we see facility-based births go up and malaria deaths go down and HIV prevention improve. It's not just the policy response, but it's people choosing to make changes and often at a huge cost to themselves. And so I think it's worth appreciating that. And especially these days, we've had declining purchasing power across the spectrum in Kenya, where at the median, purchasing power has declined about 30% since 2015. So people are making really severe trade-offs. Every time they spend 1,500 shillings to get an ultrasound, that's 1,500 that can't go to school fees, that can't go to food. These are really important trade-offs that people are making every day. But I know there's a lot of problems and we're all very aware of what a lot of those are. I do see some bright spots as well. If we look at SHA registrations, most of our counties are lagging far behind Mombasa in registration. But in terms of paying premiums, we saw a huge tick up in paying premiums and about 13% of our households. And while that might sound small, that has already surpassed NHIF and that in just like a year. So when Kenya really puts its mind to doing something, big things happen. I've also been really interested to see the huge role that chemists are playing. Dr. Kaboro, I think you're even underestimating. I think probably our one-time surveys underestimate how important chemists are in providing primary care. And while there are lots of complications with quality issues at that level, I see a lot of dedication from chemists and this infrastructure that I imagine we could really put to even better use. In terms of making sure that facilities have equipment and drugs and thinking about how telemedicine, for example, and AI through diagnostics might make huge strides in public health and primary care in particular through chemists. And the last point that really makes me excited is that we see a lot of variation in the quality of care. Of course, I'm sure you've all seen patients who receive really disrespectful, undignified care, but we also see amazing care. Like really high quality care at public and private facilities alike. That variation should trouble us, but that we see that really, really good care is possible at a relatively low cost is exciting to me and makes me filled with promise. It means that the future is here, but unevenly distributed. I wanted to highlight one aspect of challenges that we're seeing with the current primary care financing situation that's causing some real disruption. And it's related to Dr. Tracy's discussion of the referral system. And I think what we're seeing is the ways that the financing structures and incentives are really colliding with challenges around quality. And these are really entangling things in ways that are producing outcomes I think we would all be very concerned about. And one place that we really see this is in maternity care. So maternity care, as we know, has been changed pretty dramatically in the new SHA dispensation. And our understanding going into the study almost a year ago was that deliveries would be free for those who had registered for SHA at levels 2 and 3. But those facilities are saying that they're not being reimbursed for deliveries and being told that they shouldn't really be doing them. They should be at higher level facilities. But many moms can't afford to pay the premiums. And so this is causing a challenge where the healthcare workers are incentivized to send women elsewhere, places that women can't necessarily afford. And this is causing all kinds of quality issues that are leading to very close calls and even, unfortunately, some neonatal deaths in our study. I want to share just a couple of stories that highlight what I'm talking about. So in one case, we had a 38-year-old woman in a rural area who was on oral contraceptives. And for whatever reason, and maybe there was an interruption in her pills, she was pregnant. She decided to terminate the pregnancy, but didn't think she could go to a formal facility to do that. And so she got pills from a friend for 3,000 shillings. That 3,000 shillings was a huge burden, but she came up with it because she knew how important this was. She experienced some bleeding and she thought that pregnancy was terminated. It was not. So when she realized that she was still pregnant, she hid it from everyone and was really living in denial. She didn't tell her friends and family. She didn't even tell her researcher. She only went to ANC clinic at the very end of the pregnancy. And when she went there, the nurse was very angry at her and, as she recalls, was abusing her. She said, "What kind of person has 6 children in this Kasongo economy? What are you thinking? How could you do this? And you can't afford to go to get better care. You're 38 years old. Your last child was 2 years ago. You're high risk. You need to go to a level 5 facility to deliver, and you need to go and get an ultrasound." That ultrasound was 1,500 shillings. She couldn't afford to go to a level 5 facility. She couldn't afford to pay for shift premiums. So she came back to the same dispensary to deliver. And the nurse found her and was again very angry. "Why did you do this? This is high risk. I can't deliver you," and was delaying, and that nurse refused to treat her. Another nurse came in and listened to her and understood and said, "Okay, well, if you're not going to go, then let's try. Let's try to deliver the baby." So he tried and delivered the baby there. Luckily, the baby was healthy, but she had a substantial tear and they didn't have materials to stitch her. So she had to go and pay at the pharmacy for materials and come back for the nurse to stitch her. And then he decided that he wants 1,000 shillings as chai. And so she's now looking for money for that, and she's delaying the vaccination of the baby. They were out of BCG vaccination during the delivery. She's delaying going back to get it until she can find that money to thank the nurse. She's humiliated by that experience. It could have ended much worse, but all of these barriers to care, the cost of an ambulance, the cost of an ultrasound, meant that referral wasn't really an option. In another case, we had a woman who did pay the shift premiums. She was prepared and planning for her birth. And when she got to the sub-county hospital to deliver, it was during the holiday period on December 30th, and there were no staff around. So she had to go to another hospital. Luckily, because she was covered, that was okay. She gets to the other hospital, and one nurse examines her and tells her, "The baby is turned the wrong way. I think you need to be referred elsewhere." Another staff member came and told her, "Actually, you're having twins. And so you need to take an ambulance and be referred right away." So they actually sent several women at the same time to a referral facility to deliver the babies. 2 of those 3 women had normal deliveries with no complications, and were told actually they didn't have complicated cases at all. And yet also they told them SHA was not working and they would need to come up with 8,000 shillings on the spot to pay the bill there. Our respondent negotiated and bargained that down to 6,000, but still had to pay out of pocket. And so they feel betrayed. They don't trust the nurses anymore, feeling that they lied to them so that they would send them somewhere that they had to pay more. They don't trust SHA because when they tried to use it, it didn't come to their aid. And then we have probably these incentives to send them to another facility that might actually be reimbursed for the birth. So we're having this breakdown of incentives and then outcomes for the moms. In a final story, we had a woman go and deliver here in Nairobi. And the hospital that she delivered in was really rushing to get through the care. She received very minimal care, the healthy baby, healthy outcome and all of that, but they did not confirm that the baby was breastfeeding before they left. So they went home with the baby again. This was over the holidays. Baby was not doing well, not feeding, and had to then be admitted into Kenyatta with acute kidney failure for dehydration. So now we have a baby that was otherwise healthy, where if we had the right treatment at the right time, we could have avoided this huge cost. So they did have SHA, and they were admitted for 2.5 months, but the baby was very, very sick and still is very sick. At 4 months old, is only weighing 4 kgs. And we had a bill that accumulated to 500,000 shillings, and only SHA paid for 200,000. They were able to negotiate that. But again, this is a huge burden on the hospital to now cover the rest of that bill when we probably could have avoided the entire situation. So I'm just seeing the way that these all are interconnected, interwoven. Until we get the things working in concert, I think we're going to have a hard time. I'm really inspired by Dr. Kaboro's ideas about accountability. I think getting some of that feedback mechanism working really quickly is a real place for promise.
Absolutely. Thank you so much. And thanks for bringing this home. What is the cost of the barriers that we have in the financial flow for primary healthcare? It might cost us lives. We have seen this happen before. In as much as we have efforts that are being put in place, and there are some gaps that still need to be fixed. An effective referral system is key to this. and so is a critical multi-stakeholder engagement, multi-sectoral approach. Allow me to request Kaforo and Dr. Tracy, if you're still on. Yes. We have a question from Christine Omanyo. Cancer of cervix screening should be included under primary healthcare as autonomous claim code, not under gynecological request or approval. And I was wondering whether this is something you could respond to. Or if we still have Dr. Tracy. Yes.
Yes.
Yes, Lisa, on that question about the inclusion of the cancer of the cervix screening, indeed, under the benefits package that is approved, cancer cervix screening was one of the prioritized interventions. However, and that is at the primary healthcare level and the primary healthcare fund, because of course we do recognize that screening is very critical for the common cancers and especially for cancer of the cervix, which then can be prevented effectively. The challenge that has been there in terms of operationalizing that intervention as a benefit accessible to all Kenyans has been financing. But now that the benefits are being relooked at in terms of the reviews of the benefits that are supposed to happen as stipulated in the law, that is one of the critical areas that is being discussed to see how that element can be operationalized. And of course, once that is done, bearing in mind the access rules that are practical at the primary healthcare level, then that will come with that operationalization of that part of the benefits. I hope that suffices. Thank you.
Thanks, Dr. Tracy. While I still have you, we have another question from Abdi Hakim from Mandera North. Will primary healthcare financing enable its use for mentorship and supervision, given that most partners who previously supported these activities have ended their programs?
Sorry, I didn't get the first part of that question.
So he's asking if PHC financing will support mentorship and supervision, because in his setting, most of these activities were supported by partners whose programs have since ended.
Okay, thank you very much. Looking at the services, broadly speaking, looking at the transition from external funding to domestically resourced financing, definitely there is a lot of changes that are taking place and lots of discussions in terms of now relooking at how do we manage the transition, this transition period, because we're in a period where we have some services being dropped, while others, it's about making sure that we are putting in the co-financing that is required until a certain period of time. Then we have to probably take up most of those services entirely. So in that broad discussion of the transition period, we do have ongoing discussions in terms of how that financing is going to be done, the prioritization, and just to ensure that whatever services were being financed externally that are no longer financed or will no longer be completely financed from those external sources, we have a view of not wanting to lose the gains that we've made there. So therefore, it becomes an issue of prioritizing and seeing how we can have innovative mechanisms. Also, strongly looking at integrating the health services as much as possible, because then we can be able to cut costs, especially on the overhead costs, so that whatever had been picked as strategic as a priority, then it is also finds its way into the financing mechanism. So yes, those are discussions going on and plans and strategies being discussed. So that is the work in progress. Thank you.
Thank you, Dr.
Maybe,
Tracy. I do,
Dr.
yes,
just to add,
Kaforo,
yeah,
thanks.
maybe
When you
just to
handle that, please respond to Dr. Gutu's question as well.
just to add to what Dr. Tracy has said, we always need to remember, never to forget that SHA is only one part of the financiers of service in Kenya. So SHA mainly will be geared towards service delivery, specifically for facility-based services. Remember, we still have counties which are basically mandated to fund, so they still have funding. And we foresee that in times when their current funding for the primary healthcare facilities is taken over by SHA, their own funding, which is directly flowing into the administration, should also be factored so that things that are not really facility based, or for example, supervision, mentorship, trainings, etc., the counties also should be able to take up. So we should always forget that moving forward, we have 4 funds, SHA being one of the 4 funds, the others being counties, national, and other mobilized resources in the private sector.
Excellent.
All right,
Thank you, Kaforo. Yes.
Yes, thank you.
Thank you so much. Yes?
I think on the PHC regulation has been answered from Eric.
Yes, thank you so much. Thank you, colleagues, for joining us. Before I usher in Dr. Salim to give closing remarks, please share any topics you're interested in discussing at subsequent webinars. The next one will be on accountability. Please be on the lookout for the invitations through the Division of Primary Healthcare Networks. And let me hand over to Dr. Salim. Dr. Gondi, do we still have anyone under the Directorate of Primary Healthcare? All right, I do see Dr. Gutu. Thank you for giving us the closing remarks. All right. So let me appreciate our speakers today. Thank you for sharing your insights, your experiences. Please continue. Yes, Dr. Gutu.
Sorry, not unmuted my gadget, but I must sincerely thank the panelists for appearing today, because they have really handled the key issues about sustainable financing that has been a challenge. And going forward, I think these discussions will continue to really address some of the emerging issues around health financing. So panelists plus all the participants, on behalf of the Directorate, I really must say a big thank you. And thank you for moderating this session. Thank you.
Thank you, colleagues. We will send out a thank you email with some of the insights from this webinar, and also a brief on the next session. Thank you very much. Do have a lovely rest of your day.
Thank you and goodbye.
Thank you, everyone, and have a great evening.
Thank you. That's with me.